Hello everyone, welcome back. I am Dr. X, and together with my resident, Dr. Matteo, we're here today to talk with you about seizures. Today we're tackling one of the fastest, highest stakes emergencies in clinical medicine. Quick hook for you. A 24-year-old man collapses at work. Sudden fall, rhythmic shaking, shallow breathing. EMS finds him confused and barely responsive. Is this a true seizure or a mimic? And the next 2 minutes decide everything. Let's break down the chart exactly as it's structured. Section 1 from the chart: seizure versus non-seizure. Before labeling anything, we verify. Syncope with prodrome, psychogenic events with irregular movements and closed eyes, metabolic collapse, TIAs, all can mimic seizures. True seizures start abruptly, have rhythmic movements, and end with a real postictal period. The witness report in our case supports a real seizure.
Which means we move immediately to stabilization, exactly as the chart directs.
Section 2 from the chart: stabilization. ABCs first. Check glucose. If the patient is still seizing, give benzodiazepine immediately. If they're staring, subtly twitching, or not waking, think non-convulsive status and get urgent AED. Pregnancy raises concern for eclampsia, trauma or anticoagulation for bleeding, fever for meningitis. Our patient is breathing, glucose normal, shaking stopped, so we proceed. Section 3 from the chart: classification. After stabilization, determine focal or generalized onset. Focal seizures may start with one symptom and then spread. Generalized seizures start with full brain involvement. This classification directs medication later.
And the key is timing. We classify only after stabilization, not during the chaos.
Section 4 from the chart: focused history and exam. Look for provokers: alcohol withdrawal, infection, toxins, missed sedatives, metabolic issues, trauma, pregnancy. Ask witnesses about focal onset or automatisms. Examine for deficits suggesting structural lesions.
This patient drank last night but no trauma or fever, so both provoked and unprovoked remain possible.
Section 5 from the chart: workup. Labs include electrolytes, glucose, calcium, magnesium, CBC, tox when needed. Court for trauma, fever, anticoagulation, or focal deficits. MRI is preferred for a first unprovoked seizure. AED within 24 hours. Urgently if non-convulsive status suspected.
His CT and labs are normal. MRI and EEG are ordered.
Section 6 from the chart: provoked versus unprovoked. If seizure is provoked, metabolic, infectious, withdrawal, treat the cause and avoid chronic antiepileptics. If unprovoked, proceed to risk stratification.
No clear provoker yet, so we continue.
Section 7 from the chart: recurrence risk. High-risk features: epileptiform AED, structural MRI abnormalities, persistent deficits, nocturnal seizures, prior unrecognized events. These predict recurrence above 60%. Low-risk patients: normal AED and MRI have recurrence near 34% at 3 years.
And that high-risk cutoff determines long-term treatment.
Section 8 from the chart: diagnosis of epilepsy. Defined as 2 unprovoked seizures, or 1 unprovoked plus recurrence risk above 60%. His AED now shows focal epileptiform discharges. That places him in high-risk territory.
Meaning he qualifies for therapy even after a single seizure.
Section 9 from the chart: medication choice. For focal seizures: levetiracetam, lamotrigine, carbamazepine, oxcarbazepine. For generalized tonic-clonic: levetiracetam, valproate, lamotrigine. Avoid carbamazepine in generalized epilepsies like JME. Emergency sequence: lorazepam first, then levetiracetam, valproate, or phosphenotoin.
So levetiracetam is the clean first choice here.
Section 10 from the chart: counseling and safety. Avoid alcohol, sleep deprivation, missed doses. Teach families seizure first aid. Return to ED for another seizure, prolonged confusion, trauma, fever, or new deficits. Discuss driving limitations clearly.
And that completes the entire chart start to finish.
If this helped you, hit like, subscribe, and turn on notifications. More sharp clinical breakdowns are coming. See you in the next one.